School of Medicine. She completed her medical school at UNC Chapel Hill, residency at Baltimore City Hospital, and fellowship at Johns Hopkins Hospital and Sinai Hospital in Baltimore. She joined the faculty at the University of Pittsburgh in 1989, where she has served as assistant director and director of the Pittsburgh Diabetes Center and then medical director of the Center for Diabetes and Endocrine Center. She has been the Director of Quality Improvement for the Division of Endocrinology, as well as a member of the Fellowship Curriculum Committee, Interim Chief of the Division of Endocrinology, and Chair of the UPMC Diabetes Patient Safety Committee. She has participated in various clinical trials like the Barry-2D, the Look Ahead Study, and the Diabetes Sleep Treatment Trial. She serves as a member of the Professional Practice Committee, the Board of Directors, and the Research Grant Committee for the ADA, and Clinical Guidelines Committee for the Endocrine Society. I would love to talk more about her CV, but I think we are out of time, and Dr. Korytkowski, can you please start? Thank you.
All right, well, thank you very much for inviting me here, and hello to all my friends in your division here. So that was a great presentation with the case, and I think I can speak to some of that as I go through this presentation. This is a topic I've just really liked. When I first came to Pittsburgh, we were managing all the women in our center throughout their pregnancies, and now we still manage a few of the women, but now it's mainly done through obstetrics and gynecology at McGee Women's Hospital, but we still have women from the community who are being followed by their own GYNs and then or OBs, and we manage their pregnancy. Before I go into the talk, my only disclosure is that I've just completed 6 years on the ABIM, and I just want to let anyone know who's getting ready to take their boards that I will not be disclosing any exam questions. So this is what I want to go through in the next 50 minutes or so. Just to review considerations related to both pregestational and gestational diabetes. To identify the glycemic targets and how to achieve them. You've heard a little of that already. And to discuss considerations for use of non-insulin therapies for women with gestational diabetes. So gestational diabetes used to be used to refer to any diabetes that was diagnosed during pregnancy, but it's really gestational diabetes is a term that's really reserved for women who are diagnosed in the second or third trimester. Women who are diagnosed during the first trimester probably have pre-existing type 1 or type 2 diabetes. And then there's the women that we care for who have type 1 or type 2 diabetes who go on to pursue pregnancy. There are other forms of diabetes, including the genetic defects in insulin secretion, otherwise known as MODY, and other underlying endocrine disorders that I was not going to touch on individually, but they're there just to increase awareness. So what are the definitions? So diabetes in pregnancy, that can be pregestational or women who are diagnosed during the first trimester. And the criteria for diagnosis, if they are diagnosed during that time, are identical to those for the non-diabetic population, meaning a fasting glucose of 125 or 126 or higher, an A1C of 6.5% or above, or any random glucose above 200. Gestational diabetes, as I mentioned, refers to diabetes diagnosed during the second or third trimester. So, and it is recommended that any women with risk factors, which is almost the majority of women, certainly in the United States, who has risk factors for diabetes, have a random or fasting glucose or an A1C checked at the time of their first prenatal visit as a way of identifying women who may require glycemic management during pregnancy. There are several studies that looked at if an A1C is done during the first trimester of pregnancy, that a value of 5.7% in this first trimester does predict risk for GDM later in pregnancy. There's been some variability around this number. There was recently a study from Israel that said an A1C of 5.5% could predict that. But it just emphasizes the importance of following glucose during pregnancy, since it has such an impact on both maternal and fetal outcomes. If glycemic control is normal during that first trimester, then during the second trimester, it's recommended that women go through a 2-hour 75-gram oral glucose tolerance test. Although there are many places that still use the 2-step procedure, and I will go through that as well. So these are the different approaches. So the American College of Obstetrics and Gynecology adopted the Carpenter and Coustan criteria, which is the 2-step approach to diagnosing gestational diabetes. The 2-step approach involves giving a non-fasting 50-gram oral glucose challenge and values, 1-hour values that are anywhere above 130 to 140. So different areas use different criteria. Some use 130, some use 135, some use 140. But a value above that prompts a 3-hour glucose tolerance test with 100 grams of glucola. And you can see that the criteria here is a fasting of 95 or higher, a 1-hour value of 180 or higher, 2-hour 155 or higher, and 3-hour of 140 or higher. Any single criteria diagnoses someone with having gestational diabetes. And that's been a recent change. It used to be that they required 2 values above the identified targets. The American Diabetes Association, as well as the International Association for Diabetes and Pregnancy Study Group, they have moved over to using the 75-gram oral glucose tolerance test, which is used in non-pregnant individuals for diagnosing diabetes. However, the criteria are a little different. Here they use a fasting glucose of 92 or higher. The 1-hour value is similar to that for ACOG of 180 or higher, as is the 2-hour value of being 155 or higher at 2 hours. Again, any one abnormal value defines gestational diabetes, and we'll talk about pharmacologic approaches to gestational diabetes later in this talk. So why is it that it occurs why do we test at 24 to 28 weeks in women with normal glucose tolerance? Well, early pregnancy is actually, this really just looks at kind of the scheme of insulin requirements in women with type 1 diabetes, that the early pregnancy is characterized by a period of increased insulin sensitivity, where insulin requirements in women with pregestational diabetes tend to decrease. But at around 20 weeks, when the placental hormones, such as human placental lactogen and all these other hormones that sort of are associated with insulin resistance start to increase, insulin requirements also begin to increase. And in women who do not have diabetes, insulin levels sort of increase as a way of accommodating this insulin resistance. In women with gestational diabetes, who often represent a group of women who are at risk for type 2 diabetes later in life, they are unable to mount an adequate insulin response to these rising levels of insulin resistance and then develop glucose intolerance. So it's usually a relative insulin deficiency, similar to what's seen in type 2 diabetes. So what I'm going to talk about is ongoing glycemic management of the women with pregestational diabetes, and then in women who have newly diagnosed diabetes in pregnancy, how to manage them when lifestyle interventions are not sufficient, when approaches with dietary management are not sufficient to keep glucoses under desired goals. And we'll look at insulin therapy, as well as addressing the oral diabetes medications that have been used in women with gestational diabetes in several studies in several areas. We'll look at the issues of both hyperglycemia and hypoglycemia during pregnancy, transitioning pharmacologic therapy in the postpartum setting, and a bit about technology, not as much as what you had in that the past half hour, but a little information from some randomized controlled clinical trials. So the American Diabetes Association recommends insulin as the preferred agent for management of both type 1 and type 2 diabetes in pregnancy, because it does not cross the placenta in any significant amounts. And oral agents are usually considered insufficient to overcome insulin resistance in type 2 and are certainly ineffective in women with type 1 diabetes. So this just has implications for women with type 2 diabetes who are being treated with non-insulin therapies and may be under good glycemic control, but who are considering becoming pregnant, at which time the therapies they're on should be revisited even before they become pregnant so that they are on therapies that are not likely to cause any kind of harm to the fetus if they do become pregnant, and as well as looking at the level of glycemic control. So what insulins can be used during pregnancy? Well, NPH and regular insulin are considered the standard of care. They've been used for a long time. The data comes from trials where these studies have been used, but they were really never investigated for their safety of use during pregnancy. Now, as new insulins come out, they're investigated for their safety of use during pregnancy, and people sort of gradually start using them. So the insulins that are pregnancy category B that have been shown to be safe and efficacious during pregnancy without evidence of teratogenicity include the rapid-acting insulins Lispro and Aspart. There really are no studies done with Apidra, and the longer-acting insulins Detamir. These are 3 insulins that are approved for use during pregnancy. Glargine itself has not been approved for use during pregnancy. It is considered that women who are on stable doses of insulin Glargine prior to conception can continue this during pregnancy, and I'll show you some data about that. As I mentioned, there's no studies for glulisine, and there are emerging studies for Degludec. I'll show you one of these studies. There's case reports and small trials that have been published. This is data regarding Glargine. This is a meta-analysis of multiple trials that looked at both maternal and fetal outcomes. And I think it's the study that I used to make me comfortable using Glargine in women as they went into pregnancy. But this just looked in terms of maternal outcomes. The first trimester A1C with on your left would be favoring Glargine, on your right would be favoring NPH throughout all these graphs. So first trimester A1C, hypoglycemia risk for preeclampsia, and hypertension during pregnancy. And you can see all of these meta-analyses really cross this one for unity between the similarity between the 2 different approaches. Although it does look like they lean a little towards favoring Glargine over NPH. And that could be because the glycemic control might be better, even though the first trimester A1Cs were almost identical between these NPH and Glargine therapy. Of course, we don't think about just the mother, we also think about the baby during pregnancy. And again, looking at neonatal outcomes for women who are treated with Glargine throughout the pregnancy compared to NPH insulin, fetal outcomes were also the same. This would be neonatal hypoglycemia, identical, requiring admission to the ICU, again, leaning a little towards favoring Glargine, but really, again, similar to NPH. Same for risk for congenital malformations and macrosomia. So they're really considered equivalent. And I personally have become very comfortable using Glargine during pregnancy. What about Degludec? So we don't have any approval for use of using Degludec during pregnancy. There are many case reports. This is probably the largest trial I've been able to find to date. I think this was a study. This is a study that comes from the UK. It's a small trial, and these were just women who were on Degludec before becoming pregnant that used it throughout the pregnancy. So 22 women on Degludec compared to 51 women with Glargine. Risk for preeclampsia was identical. HbA1c at early in pregnancy was a little higher in the Degludec group compared to the Glargine group, but this was a non-randomized study. Late pregnancy, the A1c levels are identical. The risk for severe hypoglycemia was numerically, but not statistically significantly higher in the women getting Degludec. It's a longer acting insulin. Preterm delivery was numerically higher, but none of these were significant, but non-significantly higher in the women getting Glargine. Same for no significant difference in women requiring C-section in birth weight of the baby, risk for neonatal hypoglycemia, need for IV glucose. and they did not report on congenital malformations or perinatal death in this very small report. I personally have not used Degludec in anyone who is pregnant, but I suspect similar to Glargine, there are going to be emerging studies that will give us more data about this over time. So what are the pregnancy goals for women with diabetes? Well, I think every woman who becomes pregnant wants to have a beautiful, healthy little baby when they deliver. And so we pay a lot of attention to glycemic goals, but women are really often focused on that baby. To get there, we recommend that they try to achieve the following glycemic targets: to keep fasting glucose levels less than 95, 1 hour postprandial levels less than 140, 2 hour postprandial levels less than 120, and that is equivalent to an A1C of less than 6%. The ADA, similar to their recommendations in people who are not pregnant, they say that this is an A1C of less than 6% is the goal if it's achievable. But in women who have significant risk for severe hypoglycemia or hypoglycemia unawareness, it may be reasonable to keep the A1C of less than 7%. But during pregnancy, HbA1c is really considered a secondary measure to home blood glucose monitoring, and certainly a secondary measure to this emerging target of time and range using continuous glucose monitoring that we'll come to. I think probably all of you in this room know this about what are the adverse outcomes associated with hyperglycemia. For the mother, it's an increase in risk for preeclampsia, the need for C-section, gestational diabetes in a future pregnancy, type 2 diabetes later in life, if not immediately following delivery, or an increase in cardiovascular risk postpartum. For the child, there's an increased risk for fetal macrosomia, hypoglycemia, shoulder dystocia, fetal death, obesity later in life, and type 2 diabetes later in life. Certainly, if we look at the first trimester, there is an increase in risk for fetal malformations with higher glucose levels. So we have our targets that we aim for, and they're considered reasonable targets. And as we saw in the case that got presented earlier this morning, they're not necessarily easy to achieve, even using ranges of 70 to 180 as the range. The woman who was presented still had postprandial glucoses that often went above 180. It can be difficult to control. But the specific levels of glucose control that we should want are probably still a topic of discussion. And this area of where glucose levels should be comes from the study that was actually published in 2008, but has guided our therapy over time, called the Hyperglycemia and Adverse Pregnancy Outcomes, a study I don't think we could ethically do nowadays. But they took women, there were over 25,000 women, 9 countries, including the United States, who had glucose tolerance testing done in the second trimester. And they were grouped in 6 different subgroups according to their glucose levels, fasting 1 hours. So the 2 areas I want to call your attention to are those in category 3, where fasting glucoses are actually normal at 80 to 84. But the 1 hour values are sort of in the range of that trying to keep levels less than 140, and the 2 hour values of trying to keep the blood glucoses less than 120. If we look at those who have fasting glucose levels of 95 or higher, they're already having 1 hour glucose levels that are quite high of around 200 and 2 hour values that are about between 160 to 180. So certainly higher levels than what we would want. The women who were included in this study were not treated. They were only treated if fasting glucose levels exceeded 105 or 2 hour values exceeded 200. Everyone else was just followed throughout the pregnancy, which is, I think, why we couldn't do this study today. But then over time, they looked at neonatal outcomes according to categories of blood glucose. And what the HAPO study did is showed that there was really no particular threshold above which there was not an increase in risk for birth weights above 90%, the 90th percentile, was sort of a continual increase from completely normal up to those with really who would have overt diabetes. Requirements for C-sections over time, again, even higher here in this group that had normal fasting glucose. Neonatal hypoglycemia didn't really start occurring till the women were more significantly hyperglycemic. And then the C-peptide levels, so the hyperinsulinemia in the babies, was also increased as glucose levels increased. And the lines here are, the blue lines are fasting glucose, the yellow lines are 1 hour glucose, and the red lines are the 2 hour glucoses. So each of these areas, so any one value was predictive of these sort of changes in neonatal outcomes over time. So they found a strong continuous relationship between maternal glucose levels below those diagnostic of diabetes, but that were associated with increased birth weight and increased cord blood serum C-peptide levels, as well as other adverse outcomes. So this study has actually guided our therapy. So when do we initiate pharmacologic therapy with newly diagnosed diabetes during pregnancy? This would be at any time. It's when the fasting is above 95, when the 1 hour value during a GTT is above 140, or the 2 hour postprandial blood glucose is above 120. How do we start insulin? Well, I think there's many methods for starting. These are some general guidelines that have been given, but I'll have other guidelines for you as we go through some of the studies comparing insulin to non-insulin therapies in women with gestational diabetes. And so the approach varies with the presentation, with the degree of the hyperglycemia or the glucose elevation at the time a woman is seen. But the starting dose can be NPH, insulin of 0.2 units per kilo per day, or starting at 10 units. With a rapid-acting insulin administered is usually 1 unit for every 10 grams of carbohydrate, or 6 units for a woman who doesn't want a carb count before the meal identified as being associated with postprandial hyperglycemia. For women with fasting hyperglycemia, meaning glucose levels of 95 or higher, it's probably best to administer the NPH at bedtime. And then, as we do with all of our patients, is adjust the doses according to measures of fasting, pre and postprandial blood sugars, depending on if this is a woman with pregestational or gestational diabetes over time, with anticipated doses of up to 0.7 to 2 units per kilo per day, depending on the severity of the insulin resistance in an individual woman. Again, just sort of showing what can happen over time. In women with pregestational diabetes, that will often see a decline in insulin requirements during this early phase of pregnancy when there's more insulin sensitivity, blood volume is increasing. Some women have nausea, but then here, sort of by in the second trimester, there's like a 40 or 50% rise in insulin requirements, until this very end of pregnancy, when often in those last couple of weeks, there's a small decline in insulin requirements. Glucose monitoring. So many women still don't use CGM. For those who don't use CGM, we ask women with gestational diabetes to monitor fasting glucose as well as 1 to 2 hour postprandial glucose levels to determine if there's a need for therapy or adjustment of therapy. Pre-meal measures are needed for women with pregestational diabetes using basal bolus or insulin pump therapy, and even for some women with gestational diabetes. CGM is recommended for use in pregnancy. It's a level B recommendation from the American Diabetes Association, but they currently recommend it in combination with home glucose monitoring and to use fingerstick glucoses for determining insulin doses. I think that recommendation will change over time. It changed this year, and I suspect it will change in the coming year as well. Urine ketone testing is recommended for women with pregestational type 1 diabetes, as pregnancy is one of the considered one of the conditions where we can see euglycemic DKA or DKA at lower levels of glucose elevations. So continuous glucose monitoring during pregnancy. I'll sort of move into the closed loop, but before we got to closed loop, we went into the era of CGM, and this is the ConCEPTT study, which was a very nice study that took women actually early in pregnancy or women who were planning to become pregnant and randomly assigned them to CGM use or self-monitoring of blood glucose. The women who were randomized to self-monitoring of blood glucose, they were asked to do glucose levels 7 times a day, and there were time points during the study where they wore blinded CGM so the results could be compared to those women using CGM. So here throughout each of these graphs, the CGM is in the red lines, the control group is in the darker lines. But we see here that the HbA1c, these are the pregnant women, their HbA1cs are 6.9%. They decrease in both groups over the first 24 weeks, a slight uptick here at 34 weeks, but these were not really significantly different. The women who were planning pregnancy but not pregnant, which again, I think this illustrates very nicely how women who actually are actively pursuing pregnancy are much more motivated to drive down their A1Cs than women who are thinking about becoming pregnant. But their A1Cs were more around 7.5%. Again, more of a numerical decline in A1Cs over time compared to those with self-monitoring, but again, not significant. And then these women planning pregnancy who became pregnant, again, did have greater declines in A1C, but again, you can see the confidence intervals are quite wide, or the standard error bars are quite wide here. So what they looked at here was a couple of things. So you saw the time and range. So at baseline, the time and target was similar in the CGM group and in the control group. At 34 weeks gestation, the time and range was significantly greater in the CGM group compared to the control group, 68% compared to 61%. The time with blood sugars of less than 70 was similar at baseline, if anything, a little higher in the CGM group. And at 34 weeks, numerically, but not significantly lower in the women using CGM. And then other measures of hypoglycemia were kind of similar. Severe hypoglycemia was not significantly different, interestingly enough, with the CGM. When they looked at neonatal outcomes with the women using CGM during pregnancy compared to women doing self-monitoring of blood glucose, this is actually by country. So we have Italy, Spain. Now I'm forgetting these two countries, but none of them are the United States. I was wondering when I went through the, oh, here it is. This is Canada, UK, Italy, and Spain here. But I don't know why I didn't include the United States in this, but the percent of babies who were large for gestational age were significantly lower. So just with this small increase of time and range for blood glucose, it did seem to have an impact on fetal macrosomia. There was also fewer admissions to the NICU. There was also less neonatal hypoglycemia in the CGM group and a shorter length of hospital stay by 1 day. So the authors interpreted the results that that CGM was associated with improved neonatal outcomes. They attributed this to reduced exposure to maternal hyperglycemia. They felt that CGM should be offered to all pregnant women with type 1 diabetes using intensive insulin therapy. And they felt that this was the first study to indicate potential for improvements in non-glycemic health outcomes with using CGM. Now, this is sort of an extension. You saw with the presentation earlier, this same group from the UK that published the study in the New England Journal using a closed loop system overnight, where they showed an improvement in time and range of blood glucose when using closed loop CGM overnight. This includes both day and night. they sort of do this very slowly. They felt like just using the closed loop overnight is a period when most women are not eating, and it was easier to get women under control. And they wanted to do it over the 24 hours to see what happened during the day. This was a crossover study. So you can see here there's only 8 women in this group using closed loop, but eventually all 16 did use the closed loop system. Here they were allowed to use the closed loop system independent of being in the study. So most of the women chose to use the closed loop system here. But they were able to get the time and target, and here their time and target range was 63 to 140. So they did adjust their sensors to that range. So about 71%. The time above target range, above 140, was 28%. Below target range was about 2%. The mean glucose here was 124, and women were using the sensor most of the day. So time and range was good. They compared closed loop to sensor augmented pump. Again, it was a crossover, and they had a washout period between the crossover. The time in what they found is that there was really no significant difference in time and range, but there was a reduction in hypoglycemia less than 63, percent of blood sugars less than 50, or time with blood glucose is less than 50, the absolute number of hypoglycemic events, and then they calculated this low blood glucose index, which was significantly lower. I actually had hid this slide, but after hearing this morning's presentation, just quickly added it back in. They actually reported that they found wide variability among the women using these closed loop and sensor augmented pump therapy. So here, these are individual women. The red dots are the time with closed loop. The green dots are the sensor augmented pump therapy. And then these blue dots are the time from 32 to 36 weeks when they're using the closed loop feasibility study. And as you can see, there's some women who actually did better with the sensor augmented pump therapy than they did with the closed loop. Some did about the same. Here's another person who did worse with the sensor augmented pump than with the closed loop. And here it looks like they did better with the sensor augmented pump than with the closed loop. So they did find variability here among women, but basically they all did quite well. So their conclusions here was that closed loop was as effective as sensor augmented pump therapy, but safer because it reduced the extent and duration of hypoglycemia. And certainly they're recommending larger trials of longer duration with closed loop insulin delivery. So, and there are ongoing trials in this regard there here in the United States as well as elsewhere. But this really brings up the question about hypoglycemia in pregnancy. And this was something that I sort of had this was a question I had a personal attachment to, as early in my career here, when we were taking care of a lot of pregnant women in our center. One of the patients that I was managing had a severe hypoglycemic event and put her in the hospital. It terrified me that this happened to her. And I wondered, in my attempts to get her under such good glycemic control, did I hurt the baby by pushing for this tight glycemic control? Hypoglycemia is defined as any blood glucose value less than 60. The risk is certainly higher in women with pregestational diabetes, where prior to CGM, it was anticipated that a third of women with type 2 diabetes would experience a severe hypoglycemic event during their pregnancy. Treatment is pretty much the same, but it's recommended that they have both a protein and a carbohydrate snack. And certainly it requires adjustment of insulin doses, as we all know. But the thing I was most interested in is what does this do to the baby? And there have been animal studies that have demonstrated a teratogenic effect of maternal hypoglycemia in causing congenital malformations and growth retardation. But there's really no reports of adverse consequences of hypoglycemia on offspring, and very little that can be found, which I found reassuring, but none of us can really think of hypoglycemia as being good. And it's certainly something we want to avoid because it can certainly have adverse consequences to the mother. This is, again, a pre-CGM study of 108 women with type 1 diabetes. And it showed where the risk for severe hypoglycemic events, here being defined as needing for third-party assistance, was at the greater risk. And as you can see, it's in this time period of between really up to 20 weeks gestation, and then it kind of tapers off. So this is this period of increased insulin sensitivity. So I think we're all used to the fact that we're going to have to increase insulin dosing here in the later part of the pregnancy, but we really have to pay attention to risk for hypoglycemia here early in the pregnancy when many women may need reductions in insulin doses. The number of events, about half the women in this particular study had no events, but the other half of the women had anywhere from 1 event up to 31 severe events over the course of their pregnancy. So this was obviously an outlier here, and we all know that there are patients who are more prone to hypoglycemia than others. But certainly, you know, there was sort of median, I guess, was about 3 to 4 events in a pregnancy, which is certainly something we want to try to avoid. So I want to switch gears a little bit to the women with gestational diabetes and the use of Glyburide and metformin, and whether we can be using these and whether we should be using these in these patients. So are these good alternatives to for managing hyperglycemia or not? Again, keeping our eye on the prize of wanting a very healthy, happy baby following the pregnancy. So this is a somewhat recent study from 2018. Came from France. It was a multi-center randomized controlled trial that was designed as a non-inferiority trial. Women with a singleton pregnancy who had gestational diabetes diagnosed in the 2nd trimester, using the ADA or the IAD-PSG criteria with the single oral glucose tolerance test. They excluded women with overt diabetes, hypertension, and preeclampsia, known liver or renal disease. All women received nutrition education. Women who were overweight or obese were restricted to 25 calories per kilo per day. Those who were normal weight were given instructions for 35 calories per kilogram per day, divided over the course of the day of 3 meals and 2 snacks per day. The primary outcome here was a composite of perinatal complications, including macrosomia, neonatal hypoglycemia, and hyperbilirubinemia, but also perinatal death, need for admission to the ICU, a respiratory distress syndrome, acidosis, elevated in lactate levels, or birth injury. Maternal outcomes were also investigated, glycemic control, of course, the percent changing from Glyburide to insulin, hypoglycemia, premature delivery, perineal trauma, and maternal satisfaction with therapy. So there's a few interesting things about this study. So again, women who met criteria for pharmacologic therapy based on fasting or postprandial glucose levels we described earlier were randomly assigned to Glyburide or insulin. The Glyburide group started at 2.5 milligrams per day and had the dose increased by 2 milligrams every 4 days, then to 5 milligrams in divided doses with plans for a maximum dose of 20 milligrams. There's a couple of things that are interesting to me about this study is that the mean dose was only 5.4 milligrams in this dose. Many of the women did cross over to insulin therapy. In the insulin group, the Starting dose for prandial insulin was 4 units of rapid-acting analog given before meals, and again titrated as needed to achieve the desired postprandial glucose levels. And the starting dose for basal insulin was 4 to 8 units given at bedtime and titrated by 2 units every 2 days until the fasting glucose was under control. So the women were matched for age, BMI, they were sort of overweight, not really obese. About 20% had prior gestational diabetes. For almost 2/3, it was not the first pregnancy. The composite outcomes for neonatal outcomes were not different, but we'll look at individual values. Maternal outcomes, good control was better in the women getting Glyburide, but hypoglycemia was increased several-fold above the women treated with insulin for those getting Glyburide. Preterm delivery was non-significantly higher, although women tended to prefer Glyburide over insulin therapy. And I think the whole issue of needing to administer injections is not something that many people like to do if they don't have to. In looking at analysis of neonatal outcomes here, there was no significant difference. No significant difference for macrosomia, but hypoglycemia was significant. Neonatal hypoglycemia was significantly higher with those getting Glyburide. Hyperbilirubinemia was the same. Birth weight, no significant difference. Percent with macrosomia, no significant difference. APGAR scores a trend toward more women with more babies with lower scores in the insulin group, but not significant. No significant differences for RDS. Maternal outcomes, again, we talked about the average dose of Glyburide therapy was low, and severe hypoglycemia was much higher in the Glyburide group than it was in the insulin group, and this was significantly higher. So this was the first study assessing the effects of Glyburide on perinatal complications. There was more neonatal hypoglycemia with Glyburide. And they, interestingly, a strength of this study was they looked at neurodevelopmental outcomes at 2 years in those with neonatal hypoglycemia and found no difference in neurodevelopmental outcomes at 2 years, again reassuring for hypoglycemia. Maternal hypoglycemia was also significantly more frequent with Glyburide, even though these women had better fasting glucoses, but women treated with insulin had better postprandial glucoses that approached significance. So the conclusions of this study was that until we have better long-term safety data for the offspring with Glyburide, insulin should remain the first line of pharmacologic therapy for gestational diabetes. But Glyburide may be appropriate when women decline insulin therapy, but often being careful for risk for hypoglycemia. Then there's the question of, well, glibenclamide is the European Glyburide. Metformin and insulin for the treatment of gestational diabetes. This was a systematic review comparing all three. So glibenclamide was considered inferior to both insulin and metformin, and metformin performed slightly better than glibenclamide and slightly better than insulin, depending on what outcomes you're looking at. And this is a summary of some of the findings. That there was less maternal weight gain with metformin, and this was a systematic review of several trials. So this was found in several trials. The baseline BMI, interestingly enough, even though some of these were randomized trial, was higher in the metformin groups. There was a lower gestational age at delivery with metformin, and that's been fairly consistently shown, as well as more preterm birth. Lower rates of neonatal hypoglycemia as would be expected. There were treatment failures, meaning women needed to go on to insulin therapy. Postprandial blood glucoses were lower with the metformin. There was less pregnancy-induced hypertension. And again, in the studies that investigated maternal satisfaction, metformin therapy was preferred over insulin in the 2 studies that looked at this. In this study, they saw when metformin was compared to Glyburide, that there were no significant difference in perinatal mortality, macrosomia, or neonatal hypoglycemia. Similar treatment failures, about 16% of women in each group. But again, metformin was associated with lower birth weight, less maternal weight gain, lower incidence of maternal hypoglycemia, and a lower composite of neonatal death and serious comorbidity. So there is this sense that insulin is preferred, but metformin and Glyburide could be considered acceptable alternatives in women who cannot bring themselves to accept insulin therapy or titrate insulin therapy or advance insulin therapy. So it can be used as a backup in those women who are not able to have adequate access to insulin therapy or adequate glucose monitoring. The thing to keep in mind, though, is I've been showing pictures of these beautiful babies following delivery, but when children are born, women don't just want healthy babies, they want healthy children who thrive and do well in life and beyond. And there are some trials that make us think about metformin a little more cautiously. This is one study. This was not, these women did not have gestational diabetes, but these were women who had PCOS who used metformin during the pregnancy. It used to be thought that metformin decreased the risk of fetal loss. And the 2 areas of this particular slide I want to call your attention to is that following delivery, so this is birth, but as early as at 6 months and out to 4 years, the weight of the babies were greater than in those pregnancies where metformin was not used. And the BMIs were also greater all the way up to 4 years. In this metformin in gestational diabetes study looking at fetal outcomes up to 7 and 9 years of age, so here we know that metformin has been shown to be safe and effective related to pregnancy outcomes. At 7 years, there was sort of an increase in subcapsular and bicep skin folds and upper arm circumference at 7 years. And at 9 years, the women who received metformin, the offspring of the women receiving metformin, had greater body weight, arm and waist circumference, greater BMI, greater trend toward greater fat mass, and a trend toward greater fat volume. So these are areas that are worthy of ongoing studies. In this particular study, there was an Auckland group that did show these changes, and the Adelaide group did not show these changes. So there may be populations that are at greater risk for this than others, but it's certainly something that gives pause and makes us think about what is the best therapy to use during pregnancy. So we come to the ADA standards of care, again, of insulin being the preferred medication for treating gestational diabetes when glycemic goals are not met with lifestyle interventions alone, and that metformin and Glyburide can be alternatives, but should not be considered first-line agents. In women with PCOS who are on metformin before becoming pregnant, the recommendation is that metformin be discontinued once pregnancy is confirmed. And then there's the women who are treated with insulin who deliver. So here we see the lower insulin requirements are early in pregnancy, higher insulin requirements here during the 2nd and 3rd trimester, but at delivery, insulin requirements immediately decline to pre-pregnancy levels or even lower. And so there's a need to adjust therapy immediately. So the lower doses of insulin need to be started almost immediately following delivery. And I think this is one of the areas that raises concern with using a long-acting insulin such as Degludec, which hangs around for a long time, even though that one smaller study did not show a higher incidence. Women with gestational diabetes will often revert to normal glycemia, but many of these women will have gestational diabetes with subsequent pregnancies. Some will have sort of a pre-diabetes pattern in the early postpartum period. And then if there's no intervention with either metformin or lifestyle, a high percentage of these women will go on to develop type 2 diabetes. So this is really a sort of a point at which interventions can take place. And some of these women are actually at risk for type 2 diabetes. Women who require insulin at less than 24 weeks gestation are often at a higher risk for developing diabetes later on. And even if normoglycemia does occur in that immediate postpartum period, these women should have a 75-gram oral glucose tolerance test at 4 to 12 weeks postpartum to be sure that they have reverted to normal glucose tolerance. If the GTT is normal, they should be screened as any adult every 1 to 3 years based on risk factors, but at least with a fasting glucose or at least a postprandial glucose. So in summary, so we know that diabetes during pregnancy is associated with an increased risk for maternal and adverse maternal and neonatal outcomes. These risks are there for women with type 1 and type 2 diabetes, with congenital malformations being early in pregnancy, but risk for macrosomia being later in pregnancy. Preconception planning is important with attention to glycemic control, as this minimizes risk for the congenital defects that often can occur even before a woman knows she's pregnant. I think the thing I did not include for some reason is what the target A1C should be before for women to become pregnant, and it is less than 6.5%, although again, the ADA does make allowance for less than 7% in women who are at high risk for hypoglycemia or with hypoglycemia unawareness. We have this, the goal. The HbA1c goal during pregnancy, less than 6%. Time in range with CGM is emerging as the preferred measure for predicting macrosomia or other neonatal adverse outcomes in women with type 1 diabetes who are more likely to use CGM because we can get it covered for those women. Closed loop insulin delivery has been shown to reduce time with hypoglycemia. We have the one trial from the UK showing the time in range was similar between those who looped and those who used the sensor augmented pump therapy. Insulin is the preferred therapy for women with gestational diabetes who do not achieve glycemic goals with lifestyle interventions. So I'm sorry I'm not able to visit Cleveland, which I really enjoy a lot. There's so many really nice things to see there with the Rock and Roll Hall of Fame and the lakefronts. I bring a little bit of Pittsburgh to you with our 3 rivers, and this is our medical complex. So I appreciate your attention, and there may be some time for questions.
Thank you so much, Dr. Korytkowski. That was an excellent evidence-based and a very, very clinically relevant talk. I'm going to start with some questions that we have in the chat. We have one of our outside attendees, Farouk Kambi. Sorry if I'm butchering the name. That question has 2 questions. One is talking about the accuracy of hemoglobin A1C during pregnancy. And second, if there are any trials looking at short-acting sulfonylureas, I'm presuming they're referring to glipizide in women who are pregnant.
Those are good questions. So the accuracy of the A1C is, I mean, certainly there's an expansion of the blood volume during pregnancy, and the glycemic goals are lower. There's probably studies that have correlated A1C with time in range and glucose, and I didn't look at that specific measure. Certainly the A1C is kind of serves as a guide, but the adjustments to therapy are really made based on, for women who are monitoring glucoses at home, just on the self-monitoring of blood glucose for women on CGM, they're made on the basis of CGM. so I use the A1C and have really not questioned the accuracy. I think it's reassuring when it's where we want it to be. But if a woman has an excellent A1C, but blood glucose levels that are outside of the goal range, either high or low, that is really the stronger reason to either advance or modify therapy in one way or the other. And then the second question was using glipizide during pregnancy in place of glyburide. Well, the early studies were done with glyburide. That was the study in the New England Journal from a long time ago, which actually said that it was done in Texas and found it to be equivalent to insulin in these women who really didn't monitor blood sugars so much. I believe that there are some studies with other sulfonylureas, but I can't recall those just offhand. So most of the studies have been using glyburide.
All right. We have some raised hands. I will start with Dr. Lansing.
Hey, Mary. Excellent.
Yeah.
Hi, thank you. This is really great. What is your center's experience, or maybe your experience on starting patients on the insulin pump during pregnancy, maybe for those people who you don't seem to think that they could achieve control? Or do you think they're carrying a baby, they're now more cognizant of the detrimental effects of high and low blood sugars, that you don't really need to think about insulin pump initiation?
So, that's a really good question. And I think that question is really relevant probably to OBs who probably see more of these women. I mean, the one thing we have I feel like as an endocrinologist, that I see these are women who I know who are pursuing pregnancy. So actually that's a question I go over with my young women patients is, are they thinking about becoming pregnant? If not, what contraception are they using? If they are thinking about becoming pregnant, what insulins do I have them on, and what is their A1C? So we have a chance to do all that pre-pregnancy counseling. And then I can actually get them on the pump beforehand. I know David Nathan actually says that pumps should not be started during pregnancy, but I have started some women on pumps during pregnancy, a little more cautiously, and I feel a little more nervous about it because you don't want to lose glycemic control. But the majority of women are already on pumps before they become pregnant. But usually this is already a motivated population. I'm not sure I would take a woman who was under poor control or not monitoring her blood glucose as well. I haven't had that experience about putting them on a pump, because someone who's under poor control on basal bolus insulin can be under poor control on pump therapy as well. So, yeah, I think that must be a tough question for OBs, but I think that they do start, and here in Pittsburgh, they do start some women on pump therapy as they initiate pregnancy.
Thank you. We have Dr. Adi Mehta.
Thank you, and thank you for a very informative talk. My question is probably a little more physiologic. Don't you think that our diagnosis of gestational diabetes is highly flawed? Think about it. We use a challenge test which tells you real life. What is your sugar after a meal? Then we use a test that actually measures the ability of the pancreas to secrete insulin under maximal stimulus, which is what a glucose tolerance test is. That has nothing to do with glucose control during the pregnancy. Surely, if we can incorporate CGM in the management, surely the diagnosis of gestational diabetes should be an iPro for 1 or 2 days to see what exactly is the glucose excursion in someone who you suspect may have gestational diabetes, because that's where the physiology problem is. They have a higher excursion and expose the fetus to a higher level of glucose. So surely the diagnosis should be based on where the treatment is, not because we measure something historically that means nothing to the present pregnancy.
I think you raise an excellent point. I agree with you, and you probably are aware that the whole area of gestational diabetes and what do we measure and when do we measure it and how at what level do we start treating it is just been an area of controversy. And you see even the differences in the criteria between the oral glucose tolerance testing and even the results for where we want the 1 hour if you use the two-step method, where you want the glucose to be. Is it 130, is it 135, or is it 140? The good news is that in studies, there have been some studies that have compared fetal outcomes using these different criteria to see if one is more predictive of adverse fetal outcomes than another. There really are not major differences in the outcomes among them. So I guess it's just choosing the threshold where you're most comfortable. Certainly pregestational diabetes isn't the issue because they're already diagnosed. And so then we're just looking at the glycemic goals. But for gestational diabetes, I think you raise a good point. And I think we're just really using the guidelines to sort of guide us through therapy. They sort of give us a process to use to identify these women. But for women with just say they have an abnormal study with this artificial stimulus, with this high glucose load, then what we'll do is usually have them learn how to do home glucose monitoring, instruct them in dietary management, and not really start pharmacologic therapy unless they do start having postprandial glucoses above a certain range. You're right, though, that when they're just doing point of care glucose testing, they could be missing glycemic excursions. And I remember, I mean, you probably all remember Lois Jovanovic-Peterson, who just really was a trailblazer in this whole area of gestational diabetes and managing diabetes in pregnancy. When CGMs first came out, I remember her stories about women showing her these really good blood sugars for following a meal, but then when she put them on CGM, finding their blood sugars to be going really high. But it was the meals that they were testing after they were careful about, and then they'd have their real meal. And so we probably are missing a lot of hyperglycemia. And I think the HAPO study still keeps the question in mind, it's a controversy. Are we treating soon enough? Are we treating too soon? Are we over medicalizing pregnancy? Because the lower the threshold, the more women you're going to diagnose. But does that mean you might be treating more women inappropriately? But the higher the threshold, you may be not treating enough women. So you raise a really good point, and I think that's an ongoing area of investigation. And so I'm just really sort of showed you where we are right now, but I suspect that things will change in the future, especially with this use of CGM.
Thank you, Mary. Having drunk that thing twice, I can agree that an iPro might be easier than drinking that orange glucose drink. We have Dr. Bergera, our Institute Chair, next.
Yes, Mary, thank you so much for this great presentation. We're really sorry you are not here with us in person. I just wanted to ask you very briefly, any role or any data on GLP-1 and SGLT2 inhibitors in the use during pregnancy? And also just want to say, we hope, I really sincerely hope that we can work together in future projects, both our institutions, and thank you.
Well, Barto, it's nice to hear your voice. We miss you here in Pittsburgh. No, I don't know of any data about using GLP-1s during pregnancy, and I have not used them. The SGLT2 inhibitors, or the combined SGLT2 and 1 inhibitors, I would not use those during pregnancy. I would be very concerned about using them during pregnancy. Number one, well, for lots of reasons. Number one, there's no data about their safety in pregnancy. Number two is that we know that these agents increase the risk for euglycemic DKA in people, men and women. And then pregnancy being a risk factor for euglycemic DKA, I'd just be concerned about enhancing that risk. And we know that DKA can be associated with fetal anomalies. And I would not use those agents. So No, it's an interesting question, particularly for I think the GLP-1s are a good question, but I don't know of any data in that regard.
Thank you.
Thank you, Mary. We have a couple more questions in the chat from Dr. Sangeeta Kashyap. She says, thank you, Mary, for a terrific talk. For women with class 2 and class 3 obesity, are insulin requirements different? And are there any other clinical considerations?
Yes. Well, there are lots of, obesity is a major issue. And actually, there was just a very nice study in the Lancet Endocrinology issue about obesity in pregnancy. And I think I've been paying attention to diabetes during pregnancy, but obesity during pregnancy is also associated with adverse outcomes in babies, and also associated with risk later in life for type 2 diabetes and metabolic abnormalities in the offspring. And I think we don't pay enough attention to women who are obese who want to become pregnant. So obesity alone is a certainly women who are obese are at higher risk for developing gestational diabetes, but obesity alone is a risk factor for macrosomia. So, so yes, I mean, certainly there are issues in terms of caloric requirements and the amount of weight gain that is recommended for women who are obese. Certainly it's lower amounts of weight gain is recommended, and the French study actually modified caloric requirements in these women. I think there's a lot of individual variation, even in obese women. Some women who are obese still don't have as high insulin requirements as others who are obese. So I think it's really each woman has to be treated. The most insulin resistant woman I ever treated was on an insulin pump with U500 insulin with Glyburide and metformin, and she needed all those things, keep her blood sugars under any kind of reasonable control. So it's more, for me, my experience has just been doing whatever it takes to get the glycemic control achieved.
Thank you. I have a couple of questions, and these are a little bit of extensions from previous questions. One is, if you have a patient who's on a GLP-1 and planning to get pregnant, how soon before they try for pregnancy do you stop the GLP-1?
Well, certainly there's the weekly and the daily. I would probably stop it when a woman told me she was starting to pursue pregnancy. You know, because you don't know when she's going to become pregnant. So I would stop it then and probably recommend at least a month before she starts actively trying to pursue pregnancy. I have to confess, I haven't had that particular issue happen. I've had women on other agents that I've stopped and had them on insulin before becoming pregnant. So, but I don't think it would have to be much longer than that.
Okay, same thing. This applies to SGLT2 inhibitors as well. You kind of try to stop it a month before they start trying.
Yes, I have not had that experience. I mean, the SGLT2 inhibitors, they're very good for people with type 2 diabetes with underlying cardiovascular disease, and I haven't really had that issue in my young women patient population yet. So I'm not even sure that I'd have to really look at my patient population to see if I even have any young women on those agents. It seems like the people that I have on those agents are similar to what we've been seeing in the clinical trials. They're a little bit older. They have major cardiovascular risk factors, if not already established cardiovascular disease. But if I had them on those agents, I would stop it for at least a month before pursuing pregnancy, because we know that they have a longer half-life than we think. But it shouldn't be longer than a washout period of a month, if not shorter.
Okay. The other question I have is, we talked about screening a little bit. In women with PCOS who were on metformin, and now the recommendation is to stop the metformin at a positive pregnancy test, would you recommend screening them sooner than the 24 to 28 week GCT?
Yes, maybe not with oral glucose tolerance test, but certainly with fasting glucoses and postprandial glucoses. Yes.
Okay.
I mean, and again, women with PCOS are kind of a wide range too. Some of them some of them are on metformin because of insulin resistance, but they weren't hyperglycemic. But others have impaired fasting glucose, or they have prediabetes patterns with A1Cs of 5.7 or above. Those women I would test much sooner.
And would you test them by asking them to test at home, or would you test them in a clinic? How would you test them, logistically speaking?
I think you could do either. If they don't have diabetes, it's hard to get meters and test strips covered, so they'd have to be paying out of pocket, which are not so terribly expensive. They're not so terribly expensive where they could do periodic glucose monitoring. And we know that there's that improvement in insulin sensitivity early in pregnancy. But if they were not interested in doing home glucose testing, I would just have them do periodic fasting glucoses and probably some A1Cs as well. And with pregnancy, maybe monthly A1Cs.
Thank you. We have a question from Dr. Schumann, who's asking about any screening for sleep apnea in patients with gestational diabetes. Are there any guidelines around it?
That is a really good question, because we know that the PCOS population is enriched with sleep apnea, and we know that the type 2 diabetes population is enriched with sleep apnea. And I believe that there are studies, women with a history of GDM have a higher incidence of sleep apnea. So obesity alone. I have not tested women for sleep apnea during pregnancy, but it's a good question. And certainly if they have hypertension. So I actually, if it's a woman with PCOS who's obese, who's considering pregnancy, it would be a good idea to at least screen her for sleep apnea with one of the questionnaires, like the Berlin questionnaire or the Stop Bang questionnaire, or just our usual questions of daytime sleepiness and do you snore at night. Or if a woman has a history of gestational diabetes and is obese, particularly if their blood pressure is elevated, it would be recommended to screen them for sleep apnea as well, because the sleep apnea is much more prevalent than we realize. My hesitancy there is testing for sleep apnea and getting people to be compliant with CPAP if they have it are kind of two different issues.
Thank you very much, Dr. Korytkowski. We loved your presentation. The fact that we are 20 minutes over the presentation tells you that the presentation was much appreciated. I would like to thank our fellow Dr. Broom and our panelists once again for that out-of-the-box case. I know out-of-the-box things make us uncomfortable, but in this case, patient care takes precedence over our comfort with the patient. I would like to inform everybody of our next EMI Live, November 18th. We're going to be talking about calcium. We'll have Dr. Noura Nachavi, our first-year clinical fellow, present on a calcium-related disorder. Our panelists will be Dr. Khan and Dr. Jin, who are co-directors for our Cleveland Clinic Center of Excellence for Calcium and Bone Disorders. And then we have the guru of bone and hyperparathyroidism, Dr. John Bilizikian, presenting 7:30 to 8:30 a.m. on primary hyperpara. I hope all of you will be able to join us. Thank you once again and have a wonderful day.